Good afternoon and welcome to our oncology lecture series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you'll have the ability to ask questions via the Q&A feature located on the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Gina Landinez. Her presentation is titled Musculoskeletal Interventions in Oncology, Creating New Options When There Are None to Be Done. Dr. Landinez is a diagnostic and interventional radiologist at Baptist Health Miami Cancer Institute and Baptist Health Miami Cardiac and Vascular Institute. Her clinical research and teaching interests includes interventional oncology and palliative care, areas where minimally invasive radiological techniques are used for the treatment of various cancers and palliative needs. Dr. Landinez focuses on the treatment and management of soft tissue and bone tumors, pathological fractures and malignancies, and small bowel obstructions. She has used cryoablation as an alternative option for the treatment of desmoid tumors and has been involved in creating a unique treatment approach for palliative care and life extension. Additionally, she treats several chronic hepatobiliary processes using lithotripsy. Dr. Landinez received her medical degree from St. George's University School of Medicine in Granada, in the West Indies. She completed her surgical internship at the University of Texas Health Sciences Center at Houston, followed by a diagnostic radiology residency in the same institute. She went to complete an interventional radiology fellowship at the University of Texas and the Anderson Cancer Center. Prior to joining Baptist Health, Dr. Landinez served as an assistant clinical professor of clinical radiology at the University of California in San Francisco. She has researched intensively, including interventional oncology, interventional palliative, and healthcare disparities. She has shared her clinical knowledge and research findings in peer-reviewed medical journals and presented at national and international healthcare conferences and symposiums. She is a member of the American College of Radiology, the Radiological Society of North America, the Society of Interventional Radiology and Interventional Oncology, where she serves on several committees for these professional organizations. Dr. Landinez strives to advance achievements in health equity by increasing access to health care for minority groups and is committed to supporting women in medicine. Please, let's give a warm welcome to Dr. Gina Landinez. Dr. Landinez, what a pleasure meeting you in this forum. Thank you so much for accepting our invitation. The floor is yours. You may begin the presentation.
Thank you so much, Dr. Hakim. I so appreciate this invitation and this opportunity to share with you all something I'm incredibly passionate about. As Dr. Hakim mentioned, my name is Gina Landinez, and I'm an interventional radiologist here at Baptist. We cover both the Cardiovascular Institute and the Cancer Institute. Again, thank you to the international community and the international group for allowing me to showcase some of the really neat and innovative things we're doing here in Miami. I want to start off by saying cancer is obviously certainly a tough pathology to treat, and it has such in-depth ramifications of what that implies. And oftentimes, as interventional radiologists, we are left with kind of not the crumbs, but we are often asked for help in a MacGyver-like fashion to try to help in situations where there's really nothing left to do. And that's what I want to show you all today. Some of the things we can do when really the options have run out. I have some disclosures. And today I want to walk you through some simple objectives. I want to go over some cases of that's it as they pertain to musculoskeletal pathology. I want to review some of the indications for MSK. When I say MSK, I mean musculoskeletal, not the Institution Memorial Sloan Kettering. But I want to review some of the indications for MSK oncologic interventions, review some of the various types of interventions that we can do as they relate to oncology, and look at some clinical outcomes of our interventions. This is a very rough outline of what we're going to cover and go in depth. So I want to start with a case because I think case really elucidate the problem and the situations that as interventional radiologists we face. And these are some highlights of we do several of these cases, but these are the more some more pertinent ones that I found very uh, key to showcase what it is we can do. So this is a 63-year-old woman. She presented to us with, well, she had known stage 4 metastatic breast cancer, but she presented to the emergency room at Baptist with acute hip pain that radiated to the groin. It started hours before, the day before actually, as she was taking a shower, and she bent down. After she bent down, she said there was immediate pain. It was 10 out of 10. She actually, when I went to see her, she said it was 12 out of 10. And she was unable to bear any weight. So she was bedbound at this point. She attempted to take some analgesics at home unsuccessfully, and that's what prompted her to come to the emergency department. On imaging here on your left, you have just a regular pelvic hip X-ray, which is unremarkable. Nothing really stands out. And then on the right, we see an axial cut view through her pelvis, where on the right side, we see radiology right, we see some lucent lesions, some lytic lesions of the posterior aspect of her acetabular column. And for comparison, you have the left, which shows just what normal bone should look like. We knew she had this lesion for some time and we'd been following it. At one point, it was PET avid and it stopped being PET avid. So we'd said we thought she was in remission. In this particular instance, we did an MRI of her hip. And what we see here is a low signal line. It's very subtle. This is a T1 sequence on an MRI. And the line, what it elucidates is just a change in bone marrow. And it shows us, MRI is very effective at showing us, well, pretty good at showing us some fracture lines. And this is exactly what this is. It's a fracture line through that lytic lesion. The lytic lesion is not real visualized in the MR. But her main issues at this point were, which couldn't bear any weight on the right hip. She had functional pain. When we talk about these types of lesions, we talk about mechanical or functional pain. And what that means is every time they take a step, they hurt. They hurt in that particular area where the lesion is. And this helps me triage whether or not there's something we can offer and we can do for them to help with the pain. So whenever a patient has mechanical pain, we start sounding the alarms for there's more than we can do, and this is real. And of course, the worst part of this was that if something was not done, she was to be bedbound forever. So what are the options at this point? Routinely or usually we would consider something like an open reduction and internal fixation, which carries a large morbidity, carries some mortality, some not inconsequential mortality, and or just let the patient remain in bed for an X amount of time until she heals, which is not going to happen in the setting of cancer. So we'll go over that case later on. We'll re-review all of these cases. The second case I want to introduce to you is that of a 75-year-old woman. She also had breast cancer, advanced. It involved her bones. What's unique is she was diagnosed back in 1996, and I love this case because it also highlights how far we've come in medicine. So close to 30 years, and we've been able to keep her disease-free. And unfortunately, she presented to IVR to our clinic with some pain in her pelvic bone on the right side. She had had radiation in this area, 20 gray to be specific. And now this is her imaging on CT. We see this mixed lytic and mostly sclerotic lesion on the acetabulum, this right hip. For correlation, this is the PET to the left side of the screen, and it does have some avidity. So there is uptake of the FDG molecule in this particular area. You see it very subtle here, but I just want to correlate with where the bone is and where the uptake is. So you can see the bony changes in comparison to the other side, right from left. If you can compare, the bone on the right definitely looks diseased, and we know that there's activity, meaning there's active cancer in this area. And here are some more images of this. This is what the PET CT actually looks like. So definitely FDG avidity within, again, also another posterior column lesion. And the pain was also mechanical. So every time she takes a step, it really hurts this particular area. And part of me seeing them in clinic or seeing them in the hospital involves really teasing out where the pain is coming from. Is it really the lesion? Is it something else? Is it sciatica? Is it any sort of pelvic abnormality? Is it just overall old age? As we age, we are hurting. So it's very helpful to me to have the images side by side when I do a physical exam to truly understand what is happening, how it's happening. And oh, excuse me, not sure what's happening here. Dr. Hakeem, can you still hear me?
I can still hear you and see the screen.
Oh, not sure what happened there. I think it timed out. So let's talk about, those were two cases to kind of introduce you into the situations that we face as interventional radiologists from time to time, and we'll discuss this further. So what can we do? When we talk about MSK interventions, musculoskeletal interventions in oncology, what types of diseases are we treating? What are we looking at? When do you start thinking about doing an MSK intervention? And these are some of the indications that we most commonly get, whether it's diagnosis or treatment of things like primary bone tumors. Very commonly, we see a lot of osteoblastoma. Less commonly, but still common, chondroblastoma. Of course, a lot of metastatic bone disease. That's our primary pathology that we see. We see a lot of multiple myeloma, from diagnosis to actual treatment, any sort of painful skeletal lesion. We see imminent or existing pathological fractures and soft tissue tumors, for which we can also do a ton about sarcoma and desmoid specifically. And what are the types of interventions that we can do on these pathologies? It's really, I'd like to divide it into diagnostic intervention. So we really set the stage. A lot of these lesions are biopsied, and it helps us a lot. It helps us understand, well, of course, where is the best area to go after, one, but then two, if they're having any symptoms, we can set the stage for treatment. And on the therapeutic intervention front, we can do a variety of things. We can do things like ablation. We can insert cement to give the bone stability. We can do osteosynthesis, which is really just a fixation, either with screw or some sort of other device, and or embolization, where we cut the blood supply to the lesion. And let's explore this one by one. So the very first one is image-guided biopsy. Biopsies, I'm sure it seems kind of like a straightforward procedure. Oftentimes they can be very challenging. We have a multitude of modalities to do procedures with. They can be done with ultrasound, fluoroscopically, CT guided. It takes a lot of effort. It's a relatively quick procedure, but to get to the actual procedure, there's a lot of thinking that happens. We usually discuss the procedure, the biopsy in the morning, but before that, it's been approved and looked at by several people. So to get the patient on the table, several steps took place. It's a key element to diagnosis. It also helps us in certain areas for surveillance, like multiple myeloma, or if we're not sure what we're seeing is active tumor or not. And we do a biopsy in most bone and soft tissue malignancies. The exception is really primary bone tumors. With diagnostic imaging, we can usually diagnose an osteocytoma or chondroblastoma with a high degree of certainty with imaging alone. And I did want to bring up that point because we don't always need a biopsy. And it's helpful for us to have a PET, especially because a lot of these tumors have necrotic centers, or not every part of the tumor is active, and it helps us determine what site is active for us to go after when we're biopsying. And it's deeply embedded in all of the guidelines for bone and soft tissue tumors, but here we have it for bone cancer. It's important to note that for certain types of pathology like sarcoma, you want to be in an institution that treats these lesions. So I do want to point out we even have, as far as a biopsy MSK tumor board meeting, where we meet with our orthopods or orthopedic oncologists and we go over the biopsies. We try to have a huge open line of communication so that the right area is biopsied, and we are doing what's best for the patient, whatever treatment is indicated for the patient. And then for multiple myeloma, we usually do a bone marrow biopsy. It helps us obtain, and a bone marrow aspirate and a biopsy. It helps us obtain things like immunohistochemistry, flow cytometry. If there's an actual lesion, like in the case of plasmacytoma, we can go for the lesion itself. And then if there are any sort of renal function abnormalities, we can directly go after the kidney. So it's a multifaceted procedure that covers a ton and gives us a ton of information. In the case of sarcomas, it helps the clinical decision making. And then, of course, a lot of these biopsies go for molecular and genetic testing. So let's go over the therapeutic interventions one by one. We just covered diagnostics, and let's talk about therapeutics. And the first technique that we have, it's ablative therapies. And what ablation is what we do is we insert a probe. It's a really long needle, very sophisticated needle, and it allows for the treatment of either symptomatic pain or aggressive benign lesions. We can also do cementoplasty. These are all fixation types of procedures where we cementoplasty with or without osteosynthesis, which is just a screw or some sort of device, to help the structural reinforcement of the bone. And when we have stabilization of the bone, there is definitely pain relief that follows. And then the last one we can do is embolization, where we either do it because we're helping the surgeon to devascularize the tumor. So we kind of cut off the supply of those little vessels. And we do this under fluoroscopy. We go exactly to the tumor and we plug the tumor with various types of embolics, usually particles, well, the variety of embolics, either particles or more permanent embolics to keep the tumor devascularized, and or to help in vascular lesions for pain or for local control of the tumor. Let's discuss thermal ablation first and foremost. So when we talk about thermal ablation, and I'm emphasizing thermal, there is non-thermal ablation where you don't use any sort of either heat or cold. But for the purposes of soft tissue and or bone, we don't really use non-thermal ablation just yet. The literature is not there yet. But as for thermal ablation, we definitely use it to destroy the target tissue. And what we're doing is we're using extreme temperatures. So we will use microwave, and it's literally that microwave frequency and the microwave wave that we use for the microwave, in just a very sophisticated manner of introducing it through this probe. We have heat-based injuries. Besides microwave, we have radio frequency ablation, laser, and high intensity frequency ultrasound, which is called HIFU. And then we have one of my personal favorites, which is the cold-based injury type of ablation, which is called cryoablation. Cryo means ice. And what we do is we introduce this probe into the lesion to cover the lesion and to extend past the lesion to fully freeze it to death. It's kind of like what people go through when their skin is exposed to ice and they undergo frostbite. It's that same physiologic response. And at the bottom, we see a CT scan of an actual cryoablation. And what you see is the cryoablation ice ball covering the entirety of this lesion. I don't know if you can see the ball. It's just a different hue of gray. And that's what the ablation ice ball looks like under CT into the soft tissue. It's just a really great technology. It helps kill the tumor and to really treat the pain, because it can kind of calm down some of the nerves that are in the periphery of that of the tumor. So going back to one of the first cases I showed, this is a 75-year-old woman who had pre-advanced breast cancer. She was diagnosed back in 1996. She had had radiation to the pelvis. So at this point, she continued to have pelvic pain. The pain is starting again. You could re-irradiate the pelvis, so have the pelvis go through radiation again. However, every time you irradiate the pelvis, you expose it to fracture, and she wanted a different treatment modality. So that's how she came to our clinic. And again, before we saw this mixed sclerotic and lytic bone lesion on the right side of the pelvis. It's most towards the back. So if you focus on the posterior aspect, is where you really see the difference in bone. And to the left, we have that PET uptaking that FDG. And it allows us to see where the areas of activity are. This is very helpful to me when I'm about to do the ablation. I try to have a PET close in the 30-day window so that I truly understand the three-dimensional extension of that activity and go after it and then some. I do try to go after what we would call surgical margins, even though this is all percutaneous and inside the body. I try to extend the ablation zone past. So with the eyes, cover the whole lesion and then some, usually is anywhere from 5 millimeters to a centimeter around it. And this is the PET CT again, just to show you where the lesion was most active. The tumor was most active. So again, what do? We can radiate again. Surgery is not really something that they would go after. It would require an extensive open surgical resection, and with fixation, it's not really something that is done, especially in today's day and age. So what do? I do want to emphasize that all of these discussions and all of these cases require a village. And here at Baptist, we are very fortunate to have the entirety of the village. So oftentimes we'll discuss a lot of these cases in tumor board, the oncologists, the orthopedic surgeons, the radiation oncologists, the palliation care team, we're all in unison, or at least we try to communicate as effectively as possible to try to figure out what the best situation for that particular patient is. And that's key. All of these cases, if they really truly require a village. And I want to highlight the fact that we have all the key players of the village here at Baptist because it's important. So what I did was I decided to do a cryoablation of that active area. And how we do that is we do it under CT guidance. We put the patient here, the patient is laying on her belly, and we access the bone with a bone cannula. It's a really tiny, tiny incision, millimeters, less than half a centimeter. And through this needle, I place the probe. I create a little bit of a cavity with a drill that goes all the way through the bone, and I introduce my ablation probe. In this case, I decided to use ice, so I did a cryoablation, and that was because the sciatic nerve runs on the periphery of this bone. So the sciatic nerve is immediately around here. I'm going to point out. I don't think the picture with the sciatic nerve came through, so I'm going to point out to the area where the sciatic nerve lives. It's right around there. And in addition to me having all this guidance and all this technology available, I will, for the most part, use nerve monitoring to make sure that that sciatic nerve stays pristine throughout the procedure. And that's the cryoablation probe. You see this white area, which indicates the end of where the probe, the tip of the probe is. I do a number of probes, usually anywhere from 2 to 20, depending on how big the lesion is. But this is a second probe that we put for that particular area. And the goal, again, is to treat the actual avid zone and then some more. This is a sister case. It's a different case of a procedure in a patient with a huge pelvic lesion where we introduce a multitude of probes. Everything is done percutaneously, but it gives you an idea of what it looks like from the outside. So this, I believe, had like 15 probes. We use bony cannulas to help us go through the bone, and then through those cannulas, which are the ones in the orange cap, we introduce the ablation probes. And this patient is in the CT machine, also laying on his belly. So after this procedure, the patient, I just recently saw her. This is a recent case, and she is doing great, no pain. She's able to ambulate without assistance, and we're just monitoring that bone to make sure it gets strong again, and she's able to do her activities of daily living. Another sister case, because it's really neat what we're doing. This is an emerging technique here at Baptist. We are at MCVI. We have robotic navigation of needles. So we have a robotic arm that can help us guide us to where we want to end up in the target area we want to end up. And as you can see, the robot, it just holds the needle in place until we place the cryoablation probe or the ablation probe, whatever it may be, to the final destination. And I'm just going to quickly walk you through because it's a pretty nifty device, and it does help us with a high degree of certainty to end up where we need to be. And it makes the procedure very quick, especially when we're using numerous probes, more than one or two. So the robotic arm here has a clasp, and the clasp holds the needle in place. In this particular case, I have an 11 gauge needle. That's my bony cannula. And we are going to, it holds things in place for me to go through the skin, through all the tissues that I need to get to until I get to the bone. This is a video of the robot staying right in those same coordinates till we get as close to the skin as possible, and then we advance the needle until we're closer to the bone. And once we are in the bony cortex, I'm able to drill with various drills that we have available to us, and it helps us get just a little bite into that bone before we place the drills and the probes, etc. The robot itself also has some pretty good software built in. When we're doing ice, this is a different case. This is not the same case. These are all sister cases. But when we're doing cryoablation, or really any ablation, what we're doing is we're sculpting. We're kind of creating the shape, recreating the shape of the lesion inside of the patient. So I actually find these ablations to be, it takes a lot of being just very meticulous and thought a lot of effort and thought into making sure that we're covering the lesion to its entirety. We're not looking at the tissues directly. We're not looking at the tumor directly. We're looking at a rendering of what the tumor is, because oftentimes we don't even have PET. We can superimpose the PET sometimes also with really cool technology, but it's not perfect. So I try to be a little bit extra aggressive to make sure that we're giving the patient the best shot at fully treating the lesion. And this particular software allows me to visualize what those ice or the degree of ablation is going to be. So in the purple and the yellow, those are what I would call isotherms. And it helps me visualize the areas of ablation. And again, what I'm doing, especially with the ice, is sculpting the ice into this beautiful rendering of what the active tumor is and should be. And it gives me a great idea as to where not only I'm treating, but where the ice is extending, where I don't want it to extend into. Before we talked about the sciatic nerve, I don't want it to go into the joint space. I don't want it to go into a lot of muscle or certain vessels. So it really gives me a three-dimensional picture of what it is we're doing at the time of ablation, and it's incredibly helpful. So what are some of the outcomes? We don't have the most robust data when it comes to ablation of the bone, but we do have some data. Interventional radiology as a whole is a relatively newer specialty. We were in the 60s. We started in the 60s. In the 60s, daughter did one of the first procedures that was ever done known to man. So, we're in the not super long realm of specialties length. So we're still accumulating data. And we know that when it comes to curative intent for some of the malignant bony lesions, as it pertains to the bone directly, we have some local control that is in the high 60s. When we talk about palliative intent, so what we're doing matters. So if we're treating it to treat it fully and cure the person from having tumor, that's an important conversation to have for the patient versus are we curing it to just treat your pain because the pain is either recalcitrant or we haven't been able to fully control it, and in which case we're treating it as with a palliative intent. We know we're pretty good at treating both situations, but especially in the palliative front, we can do a lot for these patients and I always think quality of life for these patients really matter, even if they're in their later stages of their life. It's so important for them to live a full life, whatever that may mean for them. So keeping them pain-free is huge. As for the benign bony lesions, we have more robust data on this front with really great success rates over 92%, over 90% for things like osteodermatoma specifically. So for malignant bony lesions, again, we know we have some good tumor-free survival rates at 1 year in the high 60s for all the modalities, whether we're using radiofrequency, microwave, or cryoablation in the setting of oligometastatic disease. We know that it achieves effective pain relief. We know that if we do it in spinal lesions with combination of vertebroplasty or kyphoplasty and or radiation treatment, it helps pain even more. So collaboration on these situations really truly matter. The science is really pointing us to we need to collaborate more to help our patient better. And in general, tumors that are less than 2 centimeters with no cortical erosion fare better, but that doesn't really limit us to how much we can treat. And the combination of cryoablation with bisphosphonates has a synergistic effect when there are painful osseous metastases. As far as benign bony lesions, we again know that we have very high success rates, greater than 90% for all the modalities for treating specifically osteodermatoma. For other benign bony tumors, less so, just because we don't have the data, but anecdotally, we can do a lot for these benign bony diseases. The second patient, switching gears a little bit, this is the second patient that we saw in our introduction. This is a 63-year-old woman who had also stage 4 metastatic breast cancer. She came in with this debilitating hip pain. The pain extended to the groin. She couldn't walk. She was bedbound, and nothing really was working. These were the original images I showed you all with this lytic lesion in the posterior acetabulum. MRI showed this low signal fracture line, and it helps. All of these image modalities help me really understand well, first of all, I see the patient and I see whether or not the pain is coming from what I'm seeing on the imaging. And once I fully understand and make that correlation of pain to image, I can really help them a ton when I'm in the procedure room to target that area specifically. And we can replicate across the modalities what we're seeing. So this was the fracture line. This is a beautiful depiction of the fracture line, which is that posterior pelvic acetabulum, posterior column of the acetabulum. And that's what was causing her the pain. And again, she was bedbound, unable to walk, and had pain. So what we did is we brought her over to one of our IR rooms. We have great technology at MCVI Baptist, and what we can do is use various modalities. So this is a fluoroscopy image. It's a fluoroscopic image of the lower aspect of her pelvis. Right now she is tilted, so she's in the oblique position. And we're seeing one of my bony cannulas in being introduced into the pelvis. Here it's an AP view, so anterior posterior view, just the front of it, as to what it looks like. And I have the drill connected to the needle, and I'm going to navigate through the bone and through the lesion in hopes of reducing the fracture and stabilizing it with various tools, as we're about to see. So this is the needle going through and through the area of fracture, that fracture line, and everything is done through teeny tiny incisions. My incisions are less than 1/2 centimeter. Again, these are very tiny tools, so it allows a patient to get going with their lives rather quickly the next day. Part of this fluoroscopy machine is that it gives us guidance, it gives us navigational guidance, so I can see where I'm going, and I can do renderings, 3-dimensional renderings in the form of a cone beam CT. So this is what a CT looks like inside of that fluoro room. We use the fluoro machine to help us do these CT images. And on this particular image, what I have here is a bony cannula through the side. So this is a different bone entrance from the one I just showed you in the previous image. Here I'm coming through the side of that posterior acetabulum. And what I'm doing is multiple things. First, I biopsied this lesion just to see whether or not it was active. I ablated it. I didn't use ice. I used microwave. So in case there was any residual tumor, I really killed it all on that trajectory. And I later used this entry. They're kind of like these needles are like entry points. They're like the doors into the bone. I used it to place cement after I placed a screw. And this is the screw I placed from that inferior approach. I went all the way up through the bone, through the area of fracture. And what you see through the side is the cement here on the side. You see the cement. I'm not sure if you can see my arrow. Can you see my arrow, Dr. Hakeem? Yes. Okay.
Yes, yes, I can.
Perfect. And this is where the fracture line stood. That correlates beautifully with the MRI. And after I saw her in clinic, it tells me she can now walk. She's not using any sort of aid to walk, and her pain completely resolved. So 0 out of 10 by visual analog score. And this is incredibly gratifying. But also it allows the patient to go on with their life and do whatever it is that they need to. We know that the morbidity and the mortality rate for a patient that stays in bed is infinitely higher just by the nature of staying in bed. So getting them out of bed is of the essence, and we try very hard for them to do that here at Baptist. This is another sister case just showing more of the same, just a very, very large lytic lesion that we try to pack with screws and cement. At the end, we place cement to really pack the area and take care of all of the forces that happen in a pelvis, not only the axial forces every time you take a step, but the non-axial forces like torque every time you move, every time you rotate. All of this is taken into consideration with the materials we use. There are various corridors as to how we can do that on the pelvis, various corridors or pathways through the pelvis, and we can do most of them with a percutaneous approach. And there is some literature about fixation with this cemented screw, internal cemented screw procedure. This is probably the one with the most number of patients. It's a paper by Rue et al. 100 patients. They looked at safety. They looked at the palliative effects at 6 weeks, and what they discovered was that there was indeed a significant reduction of pain. So it's very good for palliative purposes. The patient stops taking as many opioids because they're not in pain anymore. The hospital course is shorter because they can, tiny incision. So they're able to get on with physical therapy and get on with their lives quicker out of the hospital. The rehab times are short, if any. Sometimes the patients can just, from physical therapy at the hospital, they can go home and continue doing rehab at home unless the fracture has been there for a long time. That's a little bit more challenging. They can usually go home very quickly. And most importantly, because we're not doing huge incisions, it allows the patient to go back to or go into systemic therapies that are so desperately needed for a lot of these patients. So it allows them to continue alongside our treatment rather quickly. Usually we don't even stop their treatment. So when do we start thinking about stabilizing or doing these fixations with screws and other devices? When there's an actual pathologic fracture, we start thinking about this. When the bone is about to fracture, so an impending pathologic fracture, we start thinking about that. And when the patient is non-surgical, that's definitely obviously an indication. And a lot of these consults I actually get from my fellow ortho oncologists, because they know how, they know when what the patient needs best. So there's definitely a lot of collaboration. Switching gears once again, and this is the last type of procedure that I want to highlight. And this is the case of a 59-year-old woman. She had stage 4 lung cancer and a carcinoma, which involved several bones, but she came in with severe pain of her left arm. She had this very large hypervascular lesion. On the right side, you have the MRI, corresponding MRI of the distal humeral diaphysis. It had a fracture. The fracture was non-displaced, and she needed to go through surgery, open reduction, internal fixation. For this particular case, what we did was different, and I just want to highlight something else that we can do, and that is embolization. So on this image, what you're seeing is a left upper extremity angiogram. We have a catheter up above here on the axillary artery, and then brachial artery, and then several various vascular structures supplying the tumor. You see very subtle there. What you see, it's a hypervascular area. That's the tumoral blush. So that's the blush uptaking all of those vascularities. And once again, you have the tumoral blush right there at the distal aspect of the left humerus, and that's what caused the bone to break. And again, that's a tumoral blush. And what we can do is go into those tiny little arteries one by one, selectively. We subselect them and we plug them with various embolic agents. In this particular situation, I use something called lava and I believe particles. So we go branch by branch. These are tiny millimetric branches, and we eradicate the blood supply to the area, and in an effort to devascularize the tumor, whether for pain control and or for surgery. So the surgeons can go and operate. Then for this particular situation, surgeons were going to operate the next day, so we devascularized the tumor. And she went on to receive the open reduction internal fixation of her humerus, and the blood loss was very minimal, only 100 cc's because of the embolization. So embolization is also a nifty tool in our armamentarium. We usually use it to devascularize any hypervascular tumor, either prior to surgical resection or if I'm going to go in the next day and ablate. We use it not just for MSK tumors, we use it for a number of various tumors, a lot of liver lesions, renal lesions, etc. So it's tools we apply to other areas of the body. And it really helps us reduce any sort of thermal sink. So that's a concept when we're ablating, where we lose energy when there are nearby vascular structures kind of taking away the energy. And then it sinks, so we don't have as much energy deposited at one given time. So that's a reason why we would devascularize it. And we also use it to treat painful bony tumors when the patient is not an ablation candidate, or when the tumor is just so large that we can't really treat it with ablation. This is another tool in our armamentarium. So in conclusion, I am trying to keep us in time here. Um, Interventional radiology has numerous tools to help. We can really truly help, and this is a passion project of mine. There's no better form of payment than a patient says, "Thank you, doctor. I'm pain-free because of you." Patient who can all of a sudden walk, who couldn't just hours before. It's incredibly rewarding to me, but also to the patient and their cohort. We can do a lot, not just for the treatment, but also for the diagnosis, both bone and soft tissue lesions. We know that a lot of these interventions allow us to palliate for pain. The hospital stays shorter. We can have the patient continue or to have a rapid return to their systemic treatments. The reduction in opioid use is significant. And when it comes to pathologic fractures or impending pathologic fractures, we know that percutaneous osteosynthesis is safe, it's efficient, it's feasible and efficacious. And we definitely should use it as much as we can. I'm so grateful for our collaborators in this effort. Multidisciplinary collaboration is key. And again, we try to keep a huge open line of communication between all the key players. And it's just exciting. There's a lot of technology and treatments that are evolving and that that we're going to see in the upcoming future, short-term future, for the treatment of various of these ailments. And with that, I thank you so much. I hope you enjoyed this. There's a lot to do and a lot to learn. I appreciate you all being here.
Dr. Landinez, we should be doing this every week until we all get on board with palliative care. This was a fantastic, fantastic presentation. Thank you so much. And yes, indeed, we did enjoy it tremendously. I love how you closed when you reflected on what patients tell you. Thank you so much, Doctor. I am pain-free finally. And that has to do a lot with the endeavors that all of you guys, especially in the oncology sector, in the oncology group, are trying to bring palliative care into play and understanding that it is not the end. These examples you gave us, 30 years post breast treatment, the person probably was in her early 40s or mid 40s, and now she comes with complaints of bone pain and probably secondary to something that is brewing. And look, there were alternatives, things that we did not hear before, Dr. Landinez. It has been quite an endeavor in oncology. And yes, you're absolutely right. We have come a long way, not only with the advent of new technologies, the use of amazing treatments, and of course, understanding that the journey for these patients with cancer is not just initial intervention, but more so wondering what is going to happen 5, 10, 20, and look, 30 years later, it's when you discover that this patient is now having this kind of issues. You mentioned in one of the cases as you were going down into the different conditions, multiple myeloma as one of the ones as a diagnosis that you have to consider. And just for clarification for the student doctors that are online, multiple myeloma, is it in your mind, is it secondary to something that was as a consequence of a particular condition, or as a new discovery, a new event that is now a diagnosis of multiple myeloma?
Yeah, no, it's a direct sequela of multiple myeloma itself in the bones. It usually goes after the bones and it causes an array of problems. Sometimes it's just the bone marrow itself that becomes fragile and then it leads to a pathologic fracture. We see it a lot in the vertebra, for example. So we can go after that and ablate. So we kill the
Yeah.
tumor and then we stabilize by doing things like kyphoplasties or vertebroplasties.
Mhm.
Um, another sequela of multiple myeloma is the plasmacytoma, which is kind of like the brother, the soft tissue component that creates these lytic lesions. So then again, we can ablate. If it's in an area where we bear weight, we can stabilize with screws or other devices. And for us, we do a lot of bone marrow biopsies for multiple myeloma purposes to either
Sure.
diagnose it or for surveillance purposes. So we're very involved in the algorithm of multiple myeloma. I hope that
Uh,
answers your question.
Yeah, yeah, it does. It does. I just wanted to make sure it's clarified for the students, especially. But I it is fascinating the amount of tools that you have in your armamentarium to determine the next course of action and then the treatment plan for these patients. I mean, you mentioned a slew of them, from ablation, cementoplasty, I'm sorry, thermoablation, cryotherapy, HIFU. I mean, that is a myriad of different avenues for you to select from. And that is, of course, puzzling to individuals that are either internists or they're not necessarily in the oncology field, as of how you select the appropriate treatment option or modality for a patient. Can you elaborate briefly as of how you go to that wonderful convoluted algorithm? Yes, you have to rely on pathology, you have to rely on history, but here's Dr. Landinez all of a sudden saying, I think cryoablation will be the best way. How do you get to that point?
Uh, the the real answer is I give our lectures on that specific question. But I guess the short answer is it depends a lot on the anatomy and what's nearby. It
Uh-huh.
depends on what else I'm doing. So if I'm stabilizing, for example, cryoablation for an ice bowl, it takes a long time. It depends a lot on how, I mean, it's just a multitude of factors to consider. But for the most part in bone, I will go a lot for the ice, so a lot of cryoablation um, because it's a little bit more forgiving with nerves. So there are a number of nerves that run around the bone. And if I touch the nerve, it's not as irritating as something like one of the heat-based
Mhm.
modalities. Size also matters. So differentiating between
Sure.
the various types of heat modalities like radio frequency versus microwave. Microwave covers a lot more.
Mhm.
But yeah, I don't, it's not really a straightforward answer. So all I'll say is if you have any situation where there's bony pain, just feel free to reach out. We would love to see the patient, interventional
Mhm.
radiologist, either here or anywhere in the world, I'm sure.
Yeah.
MSK interventions are really growing in our field, and we're seeing how much we really can do. So just call a friend. We're here. We're here to help.
Indeed. Thank you so much, Dr. Landinez. That's such a great point you make, because we do get oftentimes questions from peers from abroad, our partners in other countries, where they have these kind of cases that all of a sudden they're puzzling to them as of, we don't know if it is some kind of a fracture. We don't know if it is a new cancer. Something is developing. And because they don't have the resources or the technology, obviously they refer to us. And we love what you guys do in our MCI, where the approach is interdisciplinary, where everyone has to actually vote to go into a treatment path. I mean, you get all these scientific brains, boiling at the time when you see one pathology that requires intervention. But I think that your message is loud and clear. The fact that individuals that have had already cancer and that have been in the last stages and now come with bony pain or bone pain or a new development or metastasis of some sort in the bone, there are alternatives, there are solutions to it. And in the examples you gave, 6 weeks post cryoablation and no pain and going back to almost back to functional status prior to the development of those pains, it's just simply remarkable. Something that we did not see before, Dr. Landinez. That is, that you are now in an environment where you're not only giving hope to the patient, but more so the quality of life, especially in last stages of the disease. Lastly, doctor, I wanted to, because you left me with this thing in my mind, you're excited about new techniques, new technology, new treatments. Do you have one in mind that you're excited about, that you think that it's going to be like a wow factor also in palliative care and in treatment in the areas that you perform treatments on?
Yeah, I'm following closely. It has to do with immune modulation. So we know, not fully, but to some extent, that when we ablate, specifically into, the most we know about is with cryoablation, we're killing the area. So we're creating, it's a whole cascade of physiologic things that are happening. We have vascular injury, we're like kind of dehydrating the cell, and ultimately leads to cell death. But in the periphery of that area, we're also disturbing the microenvironment of that tumor. And it calls a various number and various types of immune cells to the area. And we are more and more understanding that microenvironment and the things we can do to the microenvironment to better kill and send the message throughout the body. So there are some studies, ongoing studies right now of injecting certain types of immune check inhibitors. I mean, there are a number of various things that can be done where after we ablate, injecting certain type of immune controls intra-arterially or directly percutaneously to see if that really affects the totality of the tumor.
Wow.
And we're really at the inception stages of that, and it's been ongoing now for a few years. I know at Anderson they were doing it when I was there, they were doing it with rats and mice, excuse me. But yeah, I do think that the immunologics of the tumors and the microenvironment, and more specific to that particular disease process or tumor or person, it's definitely the future of this, of all of what we're seeing in the cancer treatment and the percutaneous treatment arena.
That is simply exciting. Oh my goodness. And I know that in MCI, we are very keen on actually helping and moving into clinical research and activities of that nature. And of course, we're using immunotherapy, for quite some time. And you guys are doing a phenomenal work for the entire community. And we are so grateful and honestly honored to have you in our team, Dr. Landinez. I can keep you for hours and exploring your brain and getting all these exciting things out, but we want to be considerate to you. And I want to thank you for your participation in today's lecture. And to everybody that participated today, obviously, this is a recorded session. You can always go back and listen to it. And on behalf of our entire team at International, thank you once again for participating. And we look forward to seeing you again on October 1st, 2025, for a new lecture from MCI. If you do have additional questions, if you do have a patient that you consider that should have a second look, specifically because of a new process that is developing, please send it to BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We will make sure to send it immediately to Dr. Landinez for her consideration and, of course, response back to you. Thank you once again. Thank you, Dr. Landinez. Looking forward to seeing you in the hospital.
Thank you, Dr. Hakeem. Have a wonderful evening, everyone.
Thank you.